I'm lucky to have this topic given to me because this is something which is really close to my heart. And being a vascular surgeon, I would say it's almost last 15 years I've been performing vascular Doppler independently and running the non-invasive services in the hospital I've been working. And the reason to do so was because except for few operators, we were not getting enough desired information. Till it gets on, I'll just tell you briefly. So basically, when you're doing a Doppler, you want more information what you can derive physically by clinical examination. So unless until you get more information, there is no fun in getting the investigation ordered. Because clinically, if you have examined a patient who has a femoral pulse palpable and a popliteal pulse absent, you know that there is a femoral-popliteal disease. And if on the Doppler also you get the same findings that femoral artery is diseased, that's no good. So unless until you know what is the nature of disease, whether the patient is suffering from an embolic occlusion or thrombotic occlusion, whether it's a long segment atherosclerotic block, whether it's a short segment, as in the previous speaker has emphasized, whether you want to deal with endovascular intervention, whether you want to do a surgical bypass, whether you want to do an atherectomy, whether you want to combine, do a hybrid procedure, whatever you need to conceptualize what exactly the vessel looks like, and minimum investigations have to be ordered after doing a proper Doppler evaluation. I would say if a Doppler has been properly done, you do require to complement it with a digital subtraction angiogram before a therapeutic procedure, but a lot of below inguinal ligament interventions can be done, especially based on Doppler itself, if the operator is confident. And I would say that we hardly get any evaluation done pre-operatively, like a CT scan, a CT angio, or an MR angio, if we have done the Doppler ourselves and we know the details, and we can straight away take the patient for a therapeutic intervention in the hybrid lab, do a DSA, and then straight away proceed with whether a surgery or a hybrid procedure has to be done for the same patient. इसको मत दबाना है। Okay, good. So the most advantageous investigation in the hands of any interventionist, any vascular surgeon, or an intervention radiologist for that matter, I would say is a peripheral Doppler, because it becomes the hands and eyes for the same person. I would feel a handicap if I don't have a Doppler in my outpatient, and it's very essential to visualize the anatomy and what sort of pathology we are dealing with, as I told, whether we are dealing with an embolic occlusion or atherosclerotic plaque. What are the flow patterns, whether they are occlusive, whether they are normal, triphasic, biphasic, all these, and quantitate the arterial disease, whether we are dealing with just an occlusion, a short segment occlusion, or a long stenosis, and demonstrate how the disease is progressing. There was a question that why peripheral stents don't behave as good as the central stents, because their dynamics are different, because these patients, the torsion, the flexion, and whatever the dynamics these arteries go through is more what the central arteries goes through. These arteries are very long, they behave differently, they have very significant aggressive atherosclerosis, and usually the peripheral interventions are done very late, since the patients have become symptomatic late. So this is just to show how a normal triphasic signal looks like, so which has a systolic upstroke, then a diastolic recoil. Diastolic recoil is basically because of the elasticity of the vessel, and a diastolic forward flow, which usually persists, which depends on the peripheral resistance, the resistance of the peripheral bed. If there is significant peripheral resistance, which is there in young adults, healthy arteries, you will have a different sort of flow. You will have a decreased diastolic flow in the triphasic pattern, or if there is a loss of peripheral resistance, you will have a high diastolic flow, which is usually because of less organ resistance. So we must pay close attention to the Doppler signals and look for a systolic upstroke. If there is a systolic upstroke close to the area where we are performing the Doppler, we know there is a proximal high-grade stenosis. and check for a diastolic component for the level of outflow resistance. If there is a distal disease, the outflow resistance will be less because of the opening of the AV shunts which are present at the capillary level. So there will be a suction effect, there will be a blood which will be sucked towards the periphery, and there will be loss of peripheral resistance. So this is the waveform. Sometime when we have very, very diseased vessel, you will have a delayed upstroke, which means that the vessel is taking a lot of time to get filled, and then because of the low organ resistance, you will have a high diastolic flow. Then these are certain waveforms. You have to understand how the blood flows in the vessel. Normally it's a laminar flow. It's not a single column. There are multiple columns of blood which is flowing through the vessels. So when there is a disease, when there is a plaque formation along the walls, you see the laminar flow, the laminas which are close to the walls, they will be differently flowing. They will be having a different velocity with the flow. A central stream will have a different velocity. That's why there is a spectral broadening. So the this is the normal flow you see, because Doppler picks up collectively the flow of all the laminas which are there. So if there is no spectral broadening, there will be a sharp upper edge and lower edge. But if there is significant spectral broadening, which means all the laminas are at a different flow because it's a turbulent flow. It's not, there are a lot of eddy currents which are being formed in these vessels. So peripheral vessels, I would say that common femoral is very, very important. We must scan it carefully because that's the area where all our interventions begin. And with the advent of closure devices, with the advent of bigger French devices, we must scan these vessels and look for any plaques and look for a healthy area to enter before we plan any intervention. Profunda femoris is very important. It's a very, very major collateral. I would say it's a more important vessel than the superficial femoral artery. The important to see and evaluate is whenever we are planning any intervention, whether to have a therapeutic option which includes the profunda or doesn't include, depends whether we have evaluated the profunda nicely or not. Suppose you have a thrombotic occlusion, a patient has a superficial femoral artery block with a popliteal thrombus, whether you want to plan your incision on the popliteal artery or on a common femoral would depend whether the profunda has a thrombus or not, because you can't evacuate the thrombus from the profunda from the popliteal artery. So all these things become very important if we interrogate the profunda artery properly. Superficial femoral artery, I think the number of interventions, either they are the aortoiliac area and the superficial femoral artery, there are certain normal variation in the superficial femoral arteries. We must carefully look for all the pathology, must see whether there is normal change on velocity. It's not that the velocity of sudden fallen, there is some disease which is progressing proximally or distally, because there are normal flow patterns which change in the superficial femoral artery, and we must have to change sometimes. As the previous speaker has emphasized, when we decrease the frequency of the probe, when we change the probe, we can increase the depth, we can increase the penetration. So as we go distally around the adductor hiatus, we must change our probe, because sometimes in a fat patient, we might not be able to see the artery nicely. So this is how a normal flow looks like. You see a profunda, the moment you go, you shift your sample volume box. This is the sample volume box, because this will tell us what volume of blood and what lamina we are evaluating. So wherever there is a turbulence, when we evaluate this area, you will see there is increased rise in the velocity, so which shows the disease. Now, because of the interventions, newer things are evaluating. Clinically, you get a patient, okay, he is suffering from some sort of an iatrogenic AV fistula, because he had an intervention, he had a dialysis catheter, or some sort of an intervention, or it's post-traumatic. Clinically, we know by keeping a stethoscope, keeping our hand, we can evaluate. There is a bruit, we know. But what is the exact nature? At what level the defect is? We must check with the Doppler. Here, because if we don't know our anatomy properly, if we don't do a common femoral puncture in a intervention, we do a superficial femoral puncture, we know, because when we are at common femoral, the artery and veins are medial and lateral. If we go a little down, if we puncture the superficial femoral artery, the vein becomes posterior. And if we puncture, there is always a chance we can create a fistula. Pseudoaneurysms, which are very, very common because there is a gross increase in the interventions. The interventionists are becoming very, very busy. They don't have time to give proper compression. Patients are being loaded with antiplatelet drugs. The vessels are calcified. Though in higher centers, in our centers, we use closure devices regularly, but we do get to see these pseudoaneurysms. Again, you send a patient for a Doppler, he comes back saying there's a pseudoaneurysm measuring this size. That's absolutely useless information. What information you required? It's very important to understand that what vessel is involved, whether there is any neck, and most important is what is the condition of the overlying skin. Anyways, you can see that physically which vessel is involved, what is the size of the defect, what is the position of the defect, whether there is a neck available, what is the proximity of a major important branch. Suppose you have a pseudoaneurysm which has arising from the crotch of common femoral artery, which means just the bifurcation, and you know you can't plan a stent graft, because if you plan a stent graft, you will jail the profunda femoris artery. So you have to know what exactly is happening and what is the status of luminal thrombus. I'll show you certain images. If there is a significant luminal thrombus, you can't inject thrombin because it becomes very difficult. But if it's a free flowing with a small neck, you can inject thrombin and conclude the, and what is the distal flows. It's very, very important to understand the distal flows. Suppose you have a drug addict with a ruptured pseudoaneurysm and he is bleeding to death, whether you have to construct an extra anatomical bypass at the same sitting, or you have to just ligate the vessel and come out. Suppose the distal flows are already occluded, his leg is surviving on collaterals. You don't have to reconstruct that patient, any circulation in that patient at the same sitting. So see, now this patient, if we have something image like this, we know there is a suitable length available. Now this patient can be offered a surgical correction, can be offered a thrombin injection, can be offered a stent graft, depending on the circumstances. What sort of a patient we are dealing with, what is the condition of overlying skin. Sometimes we do get patients who have been tried compression aggressively and the overlying skin is totally necrosed. Sometimes you get these patients where they have achieved significant thrombosis by compression, but still there is a very small patent lumen within the pseudoaneurysm. It's very difficult to localize this, though it's possible, but sometimes it becomes difficult and tricky to inject thrombin in these patients because they can always distally embolize. Now, so many times we get reports saying SFA disease, high-grade disease in SFA. So whether it's a short segment, again, the most common disease in diabetic patients will be a diffuse disease. There will be areas of long segment. I would suggest if we can give a pictorial report which demonstrate how many multiple segments of these segments are diseased, whether it's a total SFA disease which requires a total reconstruction, or we can do a bypass, or we have to place a stent in these patients. And with velocities, we can have a good, I would say, categorization that how significant these stenosis are, how much is the pressure gradient or the velocity gradient at these, because again it's very important to see the velocity ratios. It's not that just a single value or a value of velocity. Suppose somebody has a very high velocity, you have to check the velocity ratio in a healthy segment as well as in the disease segment, and if the velocity ratios are, there is definitely criteria. If it's more than 2, it's 50% as go on. And then it's very important to understand if we are dealing with a thrombotic occlusion. We get a lot of information by history, but sometimes these patients, they present late. Now again, suppose we have a young adult who had a thrombotic occlusion, you do a Doppler, you know he has come to us in a time period where we might not be able to be lucky to do a thrombectomy because thrombus has got organized, or because the intima derives its blood flow from the flowing blood, and if the thrombus has been long duration, the intima dies, it becomes non-viable, and there are very high chances of having a recurrent thrombosis if we do a thrombectomy in these patients. But if the walls are not opposing each other, the lumen is still maintained, there are other options available. We can do an atherectomy for these patients, we can create a lumen, we can put a stent graft in these patients after creating a lumen in these patients. Again, you see how a thrombotic occlusion looks like. This is just the common femoral. The SFA origin is totally thrombotic occlused. The profunda is flowing. These patients, sometimes they have a preserved limb because they have a sudden onset of pain because the profunda is perfusing, certain collaterals are established, and their leg is preserved. So whenever we are doing a Doppler, we must identify whether, when we send a report, whether we say that it's atherosclerotic occlusive disease, because that will show plaques, the walls will be close to each other, the lumen will not be maintained, and it will be a prolonged multiple segment. SFA aneurysms, though rare, but sometimes you see these aneurysms. Sometimes you see clinically an SFA aneurysm, whether this aneurysm is amenable to a stent graft, some sort of a stent graft in the form of long Viaban or other Advanta or other stent grafts, but whether the vessel condition is so diseased and there's so much of thrombus load that it's better to do a surgical correction. So again, all these information, because when we do a CT scan, if we don't study the axial images, we might not get this information. If we just see the luminogram or the topogram, where we just see the contrast, we might feel, oh, this is a small aneurysm in the SFA, let's do it a stent graft for this patient. Again, distal anastomotic aneurysm, coming back, because of some sort of a disruption of the distal anastomosis is a very, very tricky situation to evaluate, because here we have to see, because these are not good patients to go and do a surgical intervention in these patients. So if we know that it's not a total disruption, some sort of a lumen is still maintained, the distal vessel is open, there is a flow in the distal vessel, we can again plan a stent graft in these patients. There are certain gray areas which are difficult, but I'm sure with clinical experience, with your repeated performance, you will improve. There are certain areas, especially for a distal anastomosis, because sometimes the operator might not be the surgeon who has performed the procedure. And the notes sometimes are not very, very clear that where the landing zone for the anastomosis was. And sometimes it becomes very difficult if the surgery was done 4 or 5 years. But the velocity criteria, the distal flows, indirectly we can get the information that the anastomosis is working fine. The aorta is sometimes little tricky to diagnose, but I would say that if we are able to pick up some sort of a disease in the aorta, I'll show you an image. Here, this patient, you can see that the celiac axis was stenosed. This was a patient suffering from aortoarteritis. The celiac axis is diseased. The SMA was diseased. So if you suspect that there is a significant disease and you will not punish the patient by getting an unwarranted investigation in the form of an MR angio or a CT angio, then you should be confident enough. So I would say with the visceral vessels, with the abdominal vessels, if we are confident enough to say that, okay, there is a significant disease which warrant a further investigation, which might help us in changing the plan or devising the plan of treatment, we can be liberal to order that investigation. But with peripheral arteries, we should be very, very clear that what we are dealing with. This is just to show how ectasia look. We have to differentiate between ectasia and some sort of an aneurysmal dilatation. We should not jump onto a patient that, okay, he's suffering from aortic aneurysm. And stent surveillance can be easily done, especially for the iliac, because aortoiliac areas are the one where I would say the maximum number of interventions, even in my practice, is aortoiliac and femorodistal disease. So I would say for a follow-up, it's a very, very good evaluation because we can easily see the stents. Popliteal artery is very important, I would say, especially in the areas where when we have trauma. When we have a lot of patients, when we have trauma in the casualties, if the occlusion is before the geniculars, when we do these scans regularly, you will see that before the knee, just behind the knee joint, you see these geniculars coming off. What I have observed in last 10 years is whenever the obstruction is beyond the geniculars, somehow the patient still gets a window period or they get the limb is slightly viable and you can plan the intervention, you can fix the fractures and you can do the intervention. But if the injury is above the geniculars, the limbs deteriorates very, very fast. So if you can see the geniculars coming off, then you can be little relaxed and plan the treatment. But in case you see that the obstruction is proximal to the geniculars, then we have to be very, very aggressive in these patients. And again, you can see a popliteal artery in-stent stenosis. Doppler is a very, very good modality to check for in-stent stenosis and do repeated interventions in these patients. Again, popliteal thrombus. Again, this is the image which I wanted to show you. You can see there is a thrombotic occlusion of popliteal, but you can see the geniculars had already come before the thrombotic occlusion started. So these patients again will present with a history that I had acute pain and then I had to take certain medicine and then it relieved somehow, but now he is a disabling claudicant. So you know that okay, this patient has a thrombotic occlusion. And tibial arteries are very, very important because the diabetic patients, again, these diabetic patients, they present to us when more than I would say 1 or 2 tibial vessels are involved. They are very, very late presenters because of extensive collaterals. And the importance of evaluating the tibial vessels is because now most of the interventions we are doing in these patients are through pedal vessels, a retrograde safari technique. So we must see whether we have a good landing zone. Color imaging will always facilitate you seeing the course of these vessels. Sometimes they are very calcified, so you can easily identify them with the Doppler. And must look for a segmental stenosis and occlusions. And re-entry collaterals are very important to assess what is the length, because wherever the vessels are being reformed, you know that, okay, we are dealing with this long segment, whether it's a 5 centimeter or 4 centimeter disease. This is a PTA vessel. And I would just like to show different cases that how this is just a normal flow in the PTA. And I would say this is also more or less a normal flow in a diseased infrapopliteal diffuse atherosclerotic occlusive disease in a diabetic patients where clinically pulses are not palpable. These patients are very well preserved. They don't suffer from critical limb ischemia. The only problem is they become symptomatic because of some sort of a stress or when they develop an ulcer. So if they have these sort of a flow patterns at their ankle in the posterior tibial, we know that the perfusion is reasonably preserved. Other area is some sort of an AV malformation. It's very, very important to check. This patient, you can see the vessel is hypertrophied, and when you see in a horizontal cross-sectional plane, you can see the vena comitans and the artery, all three of them are pulsating. So the moment you start seeing every day, you will find some challenging cases. So you know that this patient is suffering from some sort of an AVM. There's a AV malformation, and sometimes you have large AV malformation. The importance of a Doppler is, in a clinical examination, you can know that this is an AVM. With a Doppler, you know whether there is an arterial feeder, whether there is a major draining vein, what planes are involved, whether it's intramuscular, subcutaneous, or the whole extremity is involved. And so enough information can be derived, and at least you can counsel the patient in your outpatient that what you plan to do. And so sometimes these large AVMs you can see, and these are large pulsating venous sinuses, sometimes because they get hypertrophied in the calf area with some phleboliths also pulsating in these. And when you subject these patients to angiogram, you can see. So once you have done a Doppler, you have a fair amount of idea that what sort of disease you are dealing with, and you can counsel that patient. So somebody was talking about hybrid procedure. Now most of the advanced centers, everything is done in a hybrid OR. So we are very lucky to have a hybrid OR at Medanta. So most of the procedure, we have a duplex, on-table, C-arm, a dynamic Dyna CT available to us. So all these patients, we are managed in hybrid OR. So this patient, again, how this patient was managed, because with the Doppler, we had a fair amount of idea. With the venous excess was percutaneously taken under Doppler guidance. You can see a sheath placed in the venous excess. You can place an occluding balloon, get an arterial excess, put your glue, put your coil. There is no harm or fear of getting these things embolizing into the central venous system. You can use alcohol, you can use external compression. We have used percutaneous laser also in large venous sinuses to ablate these venous sinuses. So all these procedures can be evaluated. You can see these coils, how these coils will look peroperatively. And these are the results which you can achieve by combining all these modalities. So the same patient, you can see. So a very good result, though they will come back to you for some repeated interventions, because these are very aggressive AVMs. But all these planning and devising the protocol can be done on a Doppler. Another very important area is how the pre-occlusive artery looks. A low amplitude, a low velocity flow will be there, a thump-like flow. It will be a longitudinal pulsations will be seen, and in an occluded artery, you will see that there is obviously no flow, or there will be a monophasic, a thump-like signal, what we saw, which we just saw on the previous slide, mono-occlusive, pre-occlusive flow, and a longitudinal pulsation. You can easily see these longitudinal pulsations moving and hitting the block. As surgeons, it's very important for us to surveil our grafts. So it's very, very important, and unless until, because we know what we have done, in our hearts we know what was the nature of the artery, how the surgery went. So we know, and we have a very, very strict protocol to follow these grafts, because I'll show you some images. So distal anastomotic stenosis. So we know if there is a development of distal anastomotic stenosis, we can always salvage it with a secondary angioplasty or like a supported patency. But suppose this gets occluded, then you have to thrombolize, the procedure becomes a little aggressive, either you have to do a surgical thrombectomy. So whenever the patients, they become symptomatic or they come for a regular checkups, we must evaluate their anastomosis, and this is the same patient after doing a balloon angioplasty for the same patient. The anastomosis has nicely been opened up. These are certain PTFE grafts. PTFE grafts don't have an elastic recoil, so they won't be having a normal triphasic flows. But a vein graft over a period of time almost behaves an artery. So this is a vein graft. You can see a mid segment, a distal segment. The flows are almost like an artery, healthy artery. So there are a lot of therapeutic indications for Doppler. All the endovenous laser ablations are done in Doppler. A lot of people are in habit of getting them marked in the radiology department. I'm a strict no-no for these, because it's always very good, because the only concern with these ablations is patients, they come back that what are the chances of recurrence. And I always tell them there is no recurrence, it's always the residual veins which have been left behind. And PTAs and percutaneous access can be planned, thrombin injection, central venous accesses can be easily done under guidance. We have placed IVC filters in IC settings in sick patients with Doppler guidance, and fistuloplasties is a very, very aggressive area, because these patients, they come recurrently. So fistuloplasties can be done on a Doppler in outpatient clinics as a office practice. You don't have to take these patients to cath labs. You don't have to inject contrast in these patients. All these can be done on Doppler guidance. And I would say that The helpful hints for accurate studies will be assess the full length of all the vessels. Don't just spot check by segments. Just putting your probe on the femoral artery, okay, it's fine, just on a popliteal behind the knee. You must screen the whole patient because sometimes there could be asymptomatic high-grade stenosis which might require some sort of an attention. And pay attention to the angle and flow patterns, which are very important because they can give us some fallacies, and interrogate findings from both sides. Sometimes, you might find some abnormal findings. So it's always better to check on the other side, whether it's physiological or pathological, you can always correlate. And just to summarize, I would say that duplex scanning complemented with color flow imaging has been shown to be a valuable tool for especially identification, localization, and assessment of extremity arterial occlusive disease. And it has shown significant value preoperatively, intraoperatively, and for a long-term follow-up of these disease progression. Thank you very much. And I just wanted to conclude that we do run a comprehensive Doppler training program in Vedanta. This year will be the third time, and this is open to all the postgraduates, and we keep it absolutely free of cost for all the postgraduates. And this is a good website if you want to go on to its ultrasound, www.ultrasoundpedia.com, if you want to drive some good information regarding ultrasound techniques. Thank you so much.
Thank you very much indeed, Doctor. And since we have approximately 4.5 minutes, let's take some questions from the panelists. Dr. Tarun Grover there from Gurgaon. We have 4.5 minutes to take questions, please.
Dr. Grover, what is your advice to general physician? Should he keep a small Doppler machine on his table?
Only issue is that with the PNDT laws becoming stricter and stricter, so it's a little difficult for all the physicians because you have to have a number of training hours and all those things to have acquire a Doppler machine. But if you have all this, I would say that it will be a little more aggressive for the physicians because it's not a bad idea because they deal with acute abdomens, with all other pathologies also, which can be easily picked up with an ultrasound. And so I have seen like a lot of people who were very, I would say, proactive. They would do, even surgeons as well as physicians, they will do their own patient, they will scan their own patient themselves. So it's not a bad idea, but somebody has to be interested in it.
Second thing, how much time should a ultrasonologist should spend on a peripheral vessel?
I'm very happy that this question has been put up because I would say, the major phobia for a lot of radiology postgraduates is that they are happy doing ultrasound abdomens and antenatal ultrasound because they feel that the Doppler takes a lot of time. I would say send any trainee to us. We will train him to do any Doppler, arterial or venous within 15 minutes. Within 15 minutes.
How much time one person should spend so that he doesn't miss a major finding?
That's what I'm saying. If he, with a vascular background, whether a cardiologist, an intervention radiologist, or a vascular surgeon who knows what sort of a disease he's dealing with, because he knows some amount of history. It's very important because, sometimes the person who are performing a Doppler, they don't have any clinical sense of the disease they are interrogating. So if they have a fair amount of idea that what sort of a disease they are dealing with, I would say maximum to maximum half an hour is more than sufficient to deal with the limb.
And last question, what are the major pitfalls where the doctors are, where they do a wrong diagnosis?
Again, I would say that theoretical knowledge is not there. They don't understand what is a thrombotic occlusion. It's surprising to see a patient, 65 years old patient with an iliac block being sent and the impression says Berger's disease. So, it's not that, you have to put somebody down. It's just a matter of nobody has told them that these diseases are different. These are atherosclerotic disease. They have a different, pathophysiology altogether.
And that is pitfall in the clinical diagnosis. I'm saying pitfall while doing the Doppler test.
I would say that sometimes after...
What is the caution?
I think the caution again should be that we know our machines very well and we know our presets, because sometimes new beginners, they don't adjust the gain properly and they might miss certain flows. And sometimes the pressure in a very, very thin patient, especially for venous scan, they put a lot of pressure and the veins collapse and they feel that they are not able to see the vein or vein is thrombosed. Sometimes there are a lot of differential diagnoses, like they will misunderstood a Baker's cyst or a calf vein hematoma as a calf vein thrombosis. And so again, I would say a little history, little correlation, asking the patient, and if you know the background, that how a disease, suppose somebody says that my history is of sudden onset, we know that, probably the moment and the other side, the vessels are normal. You have a palpable vessel on one side, you don't have a palpable vessel on the other side. The history says that it's sudden onset, it's a thrombotic occlusion. It might be.
You will also recommend that one should start with the normal side also, one should have a look on the normal
Yeah,
side
definitely. You know,
Before coming to the disease side.
Yeah, it's very important. And you know, just by the time patient is lying down on the bed, you are preparing everything. Clinically, if it come for an arterial scan, there is no harm before putting the probe on his body just to examine his pulses.
There's a question from the audience, please.
You know, I would love to take that also. I have those presentations. Yeah, because because there are a lot of abnormal flow patterns and waveforms which are normal in upper limbs. So we have to understand those. So you know, we cannot, because sometimes what happens is I've seen certain clinics where they have put triphasic means this, biphasic means this, velocity criteria. They have put these stickies on the wall. So these are not a good practice to do, because there will be a lot of abnormal physiological patterns which will be there. So we cannot interpret, we have to correlate. So definitely upper limbs are a little tricky, but once you start doing it, it's not difficult.
Just one comment in lower limb arterial system. Most of the time reports are when arterial system Doppler is done by the radiologist, you will hardly find ankle brachial index mentioned over there. Most of the time it is done by the cardiologists who are doing, they do it. Because the reason is, most of the time post walking, they don't have treadmill, they don't have place to walk. How to do it? Most of the time they don't mention it at all. So it should be taken care of.
That's it. Yeah.
Sir, we are running really out of time, sir. Okay.
No, you know, it is basically like if you remember the previous speaker said that if you increase the gain, there will not be aliasing of color. The color flow might first is to have a good B mode image, and once you start having adjust your gain, the color should not come out of the image. So if the color starts coming out of the image, there is a lot of artifacts which are coming, and if you gain for a pulse wave Doppler or color Doppler is, it becomes very noisy.
That's for the color.
Yeah. 2D gain is that, you know, it has to be very, very subjective sort of finding, whatever is clear to your eyes, because, you know, these machines, they have a preset. Some have a H mode, B mode, C mode. So most of the times, these are adjusted. So you can sit with the engineer, and whatever is, like some people like a grainy image, some like a soft image, some like a cross beam image. So basically, it's very, very subjective. If higher gain becomes very bright, it will become very bright. So, and lower gain will be very, very dull. Yeah, because we are basically increasing the receptiveness of the echogenic waves which are coming back to the probe.
And can you differentiate an embolic occlusion from a normal?
Definitely. Yeah, because, you know, first of all, again, you have to understand an embolic occlusion will be somebody from infective endocarditis. We're talking about an embolus. Yeah, embolus. So embolus will be a short segment, usually involving a bifurcated artery. Arteries in the body is always artery of conduction and artery of distribution. Mostly all the atherosclerotic disease will be involved in the arteries of conduction, and the distributions are always spared. External is spared, internal is spared, profunda is spared. So the embolus usually goes and lodges themselves at these bifurcations, because there are some eddy currents or some turbulence, or these are not very smooth bifurcations. They come at a ledge. A delayed embolus can initiate in situ thrombosis. Okay, but suppose there is a in situ thrombosis, because in situ thrombosis will be in a very, very hypercoagulable, the whole vessel will be thrombosed. There is no history of any AF, there is no history of any endocarditis, so we know that there is no underlying disease which can embolize. But sometimes you see just a small, with all these hypergenic catheters, you see, because, you know, you see these staff, when they flush these catheters, they will aspirate and they will put that aspirate back. It's a very bad practice. Whenever you aspirate, discard it, take a fresh and then flush it. Because when you aspirate, you put it back, you are basically putting an embolus in it. These embolus go inside and get embolized.
Thank you very much indeed.